Hello, this is our second PowerPoint presentation on the cardiovascular lymphatic system, and this one refers to alterations of cardiovascular function. Diseases of the veins. We have varicose veins, and you know what that is. It's a vein where blood's pooled, it's distended, tortuous, and palpable. The risk factors related to this are age, female gender, family history, obesity, pregnancy, history of deep vein thrombosis, or prior leg injury. Chronic venous insufficiency, and we see this in venous stasis ulcers, patients that have diabetes, where that circulation is just not getting to the feet. Thrombus formation in veins, obstruction of the venous flow. We see this in venous stasis, venous endothelial damage, hypercoagulable states. So we know that, post-surgical trauma patients, they're all at risk of this thrombus formation. Superior vena cava syndrome. This is a progression occlusion of the superior vena cava that leads to venous distension of the upper extremities and the head. And on oncologic emergency. So this is related to superior vena cava syndrome. Hypertension is a disease of the arteries. Consistent elevation of systemic arterial blood pressure. And actually, because I made this presentation last year, they've recently lowered the standard. So now anything over 120/80 is considered high blood pressure. There's primary and secondary high blood pressure, and primary hypertension is essential. So remember, you're going to see these terms a lot, primary and secondary. Anytime something is primary, it's because of something going on with the organ. Anything you see as secondary is a result of something else going on. So if someone has hypertension because they have a narrowing of the renal arteries, which can cause hypertension, that would be secondary hypertension because it's not a condition that's directly related to the heart. And the primary hypertension, you have essential and idiopathic risk factors related to hypertension. Secondary, and we spoke about this. Complicated hypertension is chronic hypertensive damage to the blood vessels and tissues. It leads to target organ damage in the heart, kidney, brains, and eyes, and that's the unfortunate thing. That's why now it's funny. I'm seeing now people are getting treated so much earlier for hypertension than they used to. When I first started in the field, if a patient came in at 33, 34 with elevated blood pressure, the provider would say, "Oh, you're too young to have high blood pressure." Not the case now. They're put on antihypertensives. We have malignant hypertension, which is a rapidly progressive hypertension. And this is a diastolic pressure usually greater than 140, and it's life-threatening, causing organ damage. Orthostatic hypotension. I had a patient with that today. It's a decrease in both systolic and diastolic blood pressure upon standing. Lack of normal blood pressure compensation in response to gravitational changes. You have acute and chronic. Now this young man that came in today, and I could tell he was very nervous, and he was concerned because he got up out of bed and he got very dizzy, and it had never happened to him before, and he wanted his blood pressure checked. So of course, we did what we had to do, but I told him, this blood pressure really isn't going to tell us anything. Yeah, your blood pressure is fine, but it really needs to be measured when you're symptomatic. So I advised him that if this became a habit, that he would need to be seen by his primary care provider to see if there was something going on with him. All right, diseases. We have an aneurysm. An aneurysm is a local dilation or outpouching of a vessel wall or cardiac chamber. And we have different types: true, false, and the aorta is the most susceptible, especially the abdominal aorta. And I'm sure ICU nurses are familiar with these particular things. Imagine if you have a balloon and you blow that balloon up and let the air out, and blow that balloon up and let the air out, and you do that 1,000 times. What is the elasticity of that balloon going to be? It isn't going to be very strong, is it? You might be able to blow it up really big, but it's going to pop easily. And essentially, that's what's happening with an aneurysm in your abdomen. It's getting blown up repeatedly, and it's losing its elasticity and its strength. And this is a picture of an aneurysm. One of my favorite things to do is to Google pictures so that I can put them in my presentation. And these are the different types of aneurysms that there are. See this false one? There's actually a clot attached to the vessel. It's not an aneurysm. All right, thrombus, a blood clot that remains attached to the vessel wall. Okay.
I came up with
Blood clot that remains attached to the vessel wall. Risk factors include intimal injury and inflammation, obstruction or pooling of blood, the stasis, thromboembolus, and arterial thrombi. Well, we know what causes that thrombus to form, and that's why we don't want patients in bed. We want to use boots and get them up moving around and moving their legs around. I advise all of my patients that come in that are taking intercontinental flights that they need to get up and walk. And I tell them to do it every hour. An embolism is once it starts moving, and it's a bolus of matter circulating through the bloodstream, and it can be made up of a whole bunch of different things. Oh, I'm going to get the hiccups. It could be a dislodged thrombus, an air bubble. It can be amniotic fluid, an aggregate of fat, bacteria, cancer cells, or a foreign substance. All of those things are considered embolism. Now, this is a disease, Berger disease. It's an inflammatory disease strongly associated with smoking, and it's autoimmune. You're going to find more and more autoimmune disorders. The thrombi become organized and fibrotic and result in permanent occlusion and obliteration of portions of the small and medium-sized arteries in feet and sometimes hands. That's Berger disease. It causes pain and tenderness in the affected area. Symptoms are caused by slow, sluggish blood flow and can often lead to gangrenous lesions and amputations. So remember that this one is really closely associated with smoking. Raynaud phenomenon. This is a common one, episodic vasospasm in the arteries and arterioles of the fingers. Less commonly in the toes, but it can happen. Secondary Raynaud. Remember, what does secondary mean? It's happening because of something else. Because of smoking, a collagen disease, pulmonary hypertension, cold environment, myxedema. Arteriosclerosis is a chronic disease of the arterial system. Abnormal thickening and hardening of the vessel walls. Atherosclerosis. It's a form of arteriosclerosis, thickening and hardening caused by the accumulation of lipid-laden macrophages on the arterial wall, and it results in that plaque development. So that's a difference between the two. The progression is inflammation of the endothelium. Inflammation is a bad thing. You're going to learn that too. Inflammation causes many, many issues in healthcare. Cellular proliferation, macrophage migration and adherence, and then oxidation, fatty streak, fibrous plaque, and then a complicated plaque. And these are the risk factors: diabetes, smoking, high cholesterol, hypertension. And it results in inadequate perfusion, ischemia, and necrosis. And once it causes necrosis, it's over. You aren't going to regenerate that area. And this slide illustrates it quite well. Peripheral artery disease. This is an atherosclerotic disease of the arteries that perfuse to the limbs, and intermittent claudication. It's any vascular disorder that narrows or occludes the coronary arteries, leading to myocardial ischemia. Atherosclerosis is the most common cause. And here are some risk factors. And as nurse practitioners, we want to work on the modifiable, right? Because we have no control over someone's age or family history or gender. But we can help with these modifiable ones. We can get their lipids down, control their high blood pressure, get them to quit smoking. If they're diabetic, get them up exercising and keep their hemoglobin A1C below 6, and get them up moving, and a low-fat diet. Non-traditional risk factors, markers of inflammation, and thrombosis. So these are all factors related to coronary artery disease. If someone has a high density C-reactive protein, SED rate, von Willebrand factor, interleukin 6 or 18, tumor necrosis factor, fibrinogen and CD40 ligand, troponin 1, hyperhomocytemia, adipokines, infection. All of those things are non-traditional risk factors, but they still are risk factors related to coronary artery disease, and inflammation is a big thing. Myocardial ischemia is the local temporary deprivation of coronary blood. You can have stable angina, Prince-Metal angina, or silent ischemia. Oh, we have acute coronary syndromes, and these are the different names for different coronary syndromes. Myocardial infarctions are considered STEMI or non-STEMI. We have unstable angina, which is a reversible myocardial ischemia. And the myocardial infarction is the sudden and extended obstruction of the myocardial blood supply. So remember in that last presentation, we saw a picture of those vessels that feed the heart? Well, there's an interruption in those vessels, and so the heart is being deprived of oxygen, and it cannot function if it doesn't have oxygen. This results in cellular injury and death. The structures and functional changes, myocardial stunning, hibernating, and myocardial remodeling and repair, but it never comes back completely. Often it presents with a sudden severe chest pain, nausea, vomiting, sweating, dyspnea, and sudden cardiac arrest due to ischemia and left ventricular dysfunction and electrical instability can occur. And this is what a vessel looks like, or a heart looks like, that's suffered a myocardial infarction. See how this tissue surrounding is necrotic? Whoops. Oh well. And this slide illustrates it in a different manner also. Now this shows an EKG with different readings in different areas. I wish I could move my picture out of the way so you can see that. But you'll have the slides so you can look if you want. I can't go back. Pericarditis is an inflammation of the pericardium. Remember, back in nursing school, anything that says itis is an inflammation. We have cardiomyopathies, dilated cardiomyopathies, congestive hypertrophic cardiomyopathies, and restrictive cardiomyopathies, and these are disorders of the myocardium. And this is what they look like. The normal heart, dilated cardiomyopathy. Hypertrophic, see how the muscle wall is it's too thick. It's too thick, it can't pump properly. And restrictive, this one's thick too, it's also not mobile. Disorders of the endocardium, and I'm not going to go into these too much because I'm sure this is review for all of you. Valvular dysfunction, so you've got valvular stenosis, aortic and mitral. Valvular regurgitation, aortic, mitral, and tricuspid. All those valves can regurgitate, and it's exactly what it sounds like. Blood shoots back through the valves. Mitral valve prolapse syndrome occurs. Those are all disorders of the endocardium. And this is what they look like. That's what I was trying to call these little things. These are called cusps. The little flaps here, those are called cusps. Acute rheumatic fever and rheumatic heart disease. So rheumatic fever is a systemic inflammatory disease caused by a delayed immune response to pharyngeal infection by group A beta hemolytic streptococcal. And rheumatic fever is directly related to an undiagnosed group A strep throat. That's one of the reasons we're so diligent to ensure that we catch all of these little kids that come in with sore throats. So the standard of care is if they come in with symptoms of the four symptoms of strep throat is fever, stomachache, headache, and fever, stomachache, headache, and sore throat. Those are the 4 symptoms. Sometimes children come in with a stomachache, and I look at their throat and I go, oh my gosh, I've seen so much strep in the clinic this weekend, it's been outrageous. So I'm going to strep them. If the strep is negative, I'm going to send a culture to the lab because we don't want to miss any of those cases. Missing a positive group A beta hemolytic strep can lead to rheumatic fever, and we don't want that. Rheumatic fever is a febrile illness with inflammation of the joints, skin, nervous system, and heart. If left untreated, the fever can cause rheumatic heart disease, and these people suffer lifelong debilitation from this. And here are the common manifestations: fever, lymphadenopathy, arthralgia, nausea, vomiting, tachycardia, abdominal pain, and nosebleeds. Major clinical manifestations are carditis, polyarthritis, chorea, and erythema marginatum. Now, with kids like this, if they have a strep and they start complaining of joint pain, they're going to the ER because I'm concerned that this has gone on longer than it should have before it was diagnosed, and I want to get this rheumatic heart disease ruled out. Infective endocarditis. This is an inflammation of the endocardium, and it could be caused by any of these factors. The pathogenesis is damage, endocardium, blood-borne microorganism adherence, and the proliferation of those microorganisms. So that's not a good thing. You don't want to have any infection in the heart. Fever, new or changed heart murmur, petechial lesions of the skin, conjunctiva, or oral mucosa. Characteristic physical findings can be Osler nodes, which are painful erythemic nodules on the pads of the fingers and toes. So that is a very unusual finding, isn't it? If someone had these swollen pads of the fingers and toes, something's going on. It's not normal. It can be weight loss, back pain, night sweats, and heart failure too. And this algorithm shows you endocarditis. And this is what it looks like from autopsy. This is bacterial endocarditis and the destruction it's caused. We have cardiac complications from AIDS, which could be myocarditis, endocarditis, pericarditis, cardiomyopathy, pericardial effusion, pulmonary hypertension, or non-antiretroviral drug-related cardiotoxicity. Now, over the last decade, the treatment for AIDS has really come a long way. Many now don't even carry a trace of the disease. They still have it, but it isn't detected on blood tests. So it's very important that the patient remain compliant with their treatment regimen. Heart failure is a general term used to describe several types of cardiac dysfunction that result in inadequate perfusion of tissues with blood-borne nutrients. So the heart is not able to push out all that good stuff to the systemic system for one reason or another. We have left heart failure, systolic heart failure with the inability of the heart to generate adequate cardiac output to perfuse the tissues. So it just doesn't have the power to push it out. Diastolic heart failure is pulmonary congestion despite normal stroke volume and cardiac output. You can see this with myocardial hypertrophy and ischemia, diabetes, valvular and pericardial disease. That's when you've got with diastolic heart failure, these patients are definitely have wet lungs. And the different manifestations, dyspnea, orthopnea, cough, a frothy sputum, fatigue, decreased urine output, and edema. And these patients often have pulmonary edema with cyanosis, inspiratory crackles, pleural effusions, hypotension or hypertension, and evidence of an underlying coronary artery disease. Right heart failure is most commonly caused by diffuse hypoxic pulmonary disease. So this is usually caused by someone who has COPD or other lung disease. It can result from an increase in left ventricular filling pressure that's reflected back in the pulmonary circulation. High output failure, it's the inability of the heart to supply the body with bloodborne nutrients despite adequate blood volume and normal or elevated myocardial contractility. You can see this with anemia, hyperthyroidism, septicemia, and beriberi, which is actually a vitamin deficiency. And this slide illustrates right heart failure and high output failure. Shock. Now, we all know about shock. It's cardiovascular system collapse. It fails to perfuse blood to tissues adequately and leads to impaired cellular metabolism. We don't want patients to get to shock because it's very difficult to get them out of shock. We can see patients with hypotension, tachycardia, increased respiratory rate. Now, the old school used to be where, oh, if the patient's blood pressure is low, they're in shock. Well, now we've found that subtle elevations in the heart rate are actually the first signs of shock. So we need to pay very special attention to all of the vital signs. Types of shock, and here they are, the different types of shock, but they all lead to the same thing, cardiovascular collapse. And this illustrates each of them a little bit. This one does too. But see, they all lead to the same thing, whether it's anaphylactic shock, septic shock, multi-organ dysfunction syndrome, and this is a progressive dysfunction of 2 or more organ systems resulting from an uncontrolled inflammatory response to severe illness or injury. So these are the patients that come in and they've got septic shock. And oh, we don't want septic shock. There are many bundles out right now. I'm sure some of you are aware of them, the different bundles to prevent septic shock and to recognize it. So there's a big initiative in the emergency departments and in the ICUs to be able to recognize septic shock before it actually occurs, because it's very, very difficult to get someone out of it once they're in it. And this is our last slide, which just is an algorithm of the dysfunctional syndrome. So this completes the second video in our cardiovascular lymphatic system series.